Friends and colleagues, today I would like to talk about polypoidal choroidal vasculopathy, PCV for short, and the current status of diagnosis and treatment. These are my financial disclosures. PCV is a macular disorder. It is characterized by recurrent hemorrhage, both within the retina and beneath the retinal pigment epithelium. And the lesions have fundamentally two elements. And really the illustration from Rick Spade way back in 1995 still holds true today. We have an abnormal choroidal network, most likely arising from the choriocapillaris, but it already has shown some evidence that it starts to invade into the Brooks membrane. And that ends in determinations of polyp-like structures that project from the plane of the choroid towards the outer retina. So there is substance and nodularity to these polypoidal lesions. Now, the incidence of PCV is largely dependent on ethnicity and geographic location. If you see in the Western Caucasian population, they are generally less than 10%. They account for only a small percentage of patients presenting with exudative or wet type AMD. But in Asia, the story is very different. Certainly in Oriental Asian populations, they can account for up to 50% of cases presenting with exudative maculopathy, and I think most authorities agree that it lies somewhere between 30 to 40%. Now, the clinical manifestations of PCV are very diverse. It can present as pigment epithelial detachments, hard exudates. You can have subretinal orange nodules, and these are the typical lesions that protrude from beneath the RPE. You can have even central serous-like lesions, and of course, hemorrhage may be a feature in some of these patients. Well, it was once thought that natural history was very good compared to typical choroidal neovascularization, but we know that it is often a remitting, relapsing type of disease. So you have patients with long histories of chronic recurrent detachments as well as hemorrhage. Now, the prognosis may be slightly more favorable, but more than a third of patients actually suffer significant visual loss, either from fibrosis, disciform scarring, atrophy of the RPE, cystic degeneration, and even in very severe cases, breakthrough vitreous hemorrhage and ptysis bulbi. Now, the characteristic findings, as I mentioned, are the clinically visible orange nodule that you can see as shown here. But this is only seen in about half of clinical cases. And really, it is the angiography using indocyanine green that reveals the true nature of the disease. Hypofluorescent halos around early nodular hyperfluorescence within the first 5 to 6 minutes. It is now widely accepted that indocyanine green angiography is the gold standard for diagnosis because it allows good visualization of the branching vascular element, or BVN, with determination of the focal early nodular hyperfluorescence. And to appreciate nodularity, one must routinely ask for stereoscopic angiograms on the ICG. The treatment options depend on the location of these active polyps. If they are in an extrafoveal or juxtafoveal location, I think focal laser photocoagulation still has a strong place. But when they are subfoveal or very near to the fovea, then we have to look at other options. Verteporfin PDT in the era before anti-VEGF was used to some extent quite successfully, and of course other combinations, initially with triamcinolone and more recently with anti-VEGF. Now, focal laser ablation, as I said, is effective in closing extrafoveal polyps with good resolution of exudation. 9 out of 10 patients have good results initially. So in the short term, very effective and quite safe. And the main drawbacks remain recurrence and choroidal neovascularization. Here, a case from a good friend, Won Ki, successful laser initially, the lesion is closed, hemorrhage resolved, and then 12 months later, a new crop of polyps appears in a previously untreated area, and this time with even more severe hemorrhage. So you're going to be faced with this type of situations when you do focal laser. Be prepared for recurrences and to be able to identify new crops of polyps and having to chase them around the macula. Now, verteporfin therapy has a unique angio-occlusive mechanism mechanism. So we know that it can close polypoidal lesions. In fact, in many series now, up to 100% of cases will have closure of these polypoidal structures. Subretinal hemorrhage after full fluence photodynamic therapy is still a problem. It occurs in about a third of patients and may even result in breakthrough vitreous hemorrhage. There's, of course, good rationale for using anti-VEGF. We know that VEGF is also upregulated in PCV, not just in neovascular AMD. And even in histopathological segments, we know that VEGF is upregulated. So when we treat it with an anti-VEGF agent like ranibizumab, the polypoidal lesions themselves do not change, but the visual acuity improves because the anti-permeability effects of ranibizumab works in reducing exudation and normalizing retinal thickness. So what happens if you leave these polypoidal lesions behind? They have a high propensity for further progression and ultimately hemorrhage. So there is a good rationale to consider combination, both PDT with anti-VEGF. The angio-occlusive effect of PDT, we know, very effectively closes polyps, and the anti-VEGF properties help to ameliorate the negative effects of PDT, such as macular hemorrhage, increased exudation from VEGF upregulation, or even the risk of RPE ribs. Anti-VEGF is very effective in improving visual acuity because of its anti-permeability effect. So the potential advantages of this type of combination therapy would be fewer treatments, fewer complications. So this is where Everest comes in. It was part of the Summit group of trials. The first two, Denali and Mont Blanc, specifically studied the role of combination therapy in neovascular AMD, and Everest was conducted in Asia looking at its effect on PCV. This was first prospective, randomized controlled trial over 19 Asian sites. Full fluence PDT was used in the same day as ranibizumab in 3 arms randomized to combination verteporfin alone and ranibizumab alone. And these cases were followed up for 6 months. It's important, I think, to understand how we arrived at diagnostic criteria, and this is the first important step toward having some kind of general universal acceptance of diagnosis. Early subretinal focal hyperfluorescence seen on the ICG, certainly within the first 5 to 6 minutes, plus one of the following: nodularity on stereoscopy, presence of a halo which was hypofluorescent, a BVN, a branching vascular network, or an orange nodule on clinical examination. And if you see massive hemorrhage and certainly pulsatile filling, this is seen on the video angiography of the SLO, these were all important criteria that allowed the diagnosis of PCV. And these were the results. At 6 months, the primary endpoint was how often could we achieve complete regression of these polypoidal lesions. That was our main aim. You see here over 70%, close to 80% of the combination, and certainly PDT alone was 70% compared to only under 30% for Lucentis alone, and these were highly statistically significant. In other outcome measurements, mean change of polyp area was the greatest decrement was seen in the combination group. Mean change, the trend was towards the best results, again with combination therapy, followed by Lucentis alone, and then last of all PDT alone. So this is quite clearly showing that the combination therapy may yield better visual results. And this is mirrored in the changes or the reduction in central retinal thickness, again greatest seen in the combination therapy compared to Lucentis. The number of ranibizumab treatments was also fewer, 3.9 versus 5.2. So to conclude, polypoidal choroidal vasculopathy is certainly more common than we used to think. It accounts for at least 30% of exudative maculopathy in Oriental Asians. Indocyanine green angiography is the gold standard for the diagnosis of PCV. Extrafoveal lesions may be safely treated with laser photocoagulation, but beware of recurrences. Verteporfin PDT produces good anatomical and functional outcomes in terms of the regression of polyps. Anti-VEGF on its own can resolve its exudation, but often fails to close these lesions down. And therefore, Everest is useful as a guide. It is the first and only prospective trial to date to demonstrate that PDT with or without Lucentis was superior to Lucentis alone. Combination of PDT and anti-VEGF is therefore an effective treatment to reduce the number of treatments, to reduce complications of PDT, while still achieving the visual results that we expect with anti-VEGF. And I'm happy to say that we are already embarking on part 2 of Everest, really looking at long-term results in the larger group of patients. Thank you very much for your attention.